It's a great honor and pleasure to be talking among two very famous oncologists, Dr. Ang, Dr. David Sudensky. My job here is actually a very short one. Just like cancer care, the oncologist will take care of you from the beginning. The surgeon comes and takes center stage for a short while, and then the oncologist takes over again. Okay? But this short time that I have on stage, I want to share with you some of the advances in cancer surgery and take you through. To understand the advances in cancer surgery, one of the best ways is to see how treatment has evolved over the years. I like to remember what Sir Francis Bacon has said many, many years ago. He that will not apply new remedies must expect new evils, for time is the great innovator. So I want you to open your minds today to listen to some of the new things that we have in terms of cancer surgery. And to take you through this, I want to go through some of the things that have helped us evolve, helped us advance. And the history of surgery, history of cancer surgery, is actually the history of surgery. We must remember that we are only able to do the things that we do today because many, many, many years ago, great men have invented anesthesia, asepsis, blood transfusion. These are the founding stones by which we are able to do bigger and bigger surgeries today. Now, in the beginning, in the early 20th century, there was no real scientific rationale for cancer surgery. People believed that cancer starts at the focus and it grows. Okay? So whenever we want to treat cancer, we just take out as much of the cancer as possible. Okay? There's no scientific reason for doing what we do. The people believed that cancer was autonomous of the host. In other words, just cancer was there and it just grow and grow and it spreads in an orderly and mechanical fashion. And there was no other treatment other than surgery. Okay? And if you fail to do proper surgery, the patient will die of the cancer. Okay? So the principle of surgery at that time was a principle of maximum mutilation. As Dr. Ang has told you, for example, in breast cancer, people believe that the more tissue you took, the better. So the surgeons in the old days, Sir William Halstead's radical mastectomy, what they did was not just remove the cancer in the breast, but they removed the skin, the fat, the lymph nodes, and even the chest muscles. This operation is very mutilating. You end up with a big hole like that. And other radical mutilating surgeries that they used to do in the past. Look, if you have a cancer in the face, they take out your face. If you can't see this, but this guy had a tumor in the hand, and they take out the whole upper limb. Or in some cases, even take out the whole bottom half of your body. Take out the entire pelvis and your lower limbs. So these surgeries were not only very mutilating, they leave you with very, very poor quality of life. Many patients die. So this is the early operation for breast cancer. You can see that you remove everything, including the chest muscles. You can even see the ribs. So it's very disfiguring, but not only that, we found that even despite doing such a big operation for a tumor in the breast, and yet the cancer has recurred. Okay, cancer was not cured. The reason for this, people have begun to found, was that cancer is actually not a localized disease. Cancer is always a systemic disease. And this is the work of two doctors, the Fisher brothers, who, based on scientific observation, found that the difference between mastectomy, doing the removal of the breast, or if you just remove just the lump alone, or remove the lump plus radiation, the survival is equivalent. The survival is equivalent. In other words, sometimes doing very, very radical surgery may not be necessary. So from the 1960s onwards, cancer surgery began to take on a scientific basis. Laboratory and clinical research showed that cancer has a complex host-tumor relationship. Okay? Cancer is a systemic disease. It spreads to the local regional area by direct invasion. It spreads to the lymph nodes around the cancer, but it also spreads to distant areas by cancer moving into the bloodstream. And therefore, the emergence of chemotherapy as systemic therapy. So like Dr. Ang has said, even when there is no identifiable spread of cancer to the rest of the body, adjuvant chemotherapy has been found to be useful to kill these microscopic cancer cells. Okay, so this is the concept of two-prong cancer treatment. Not just cancer surgery alone, but cancer surgery plus some sort of systemic therapy. So surgery, the aim of surgery is for local regional control. We remove the organ with the cancer. We remove the surrounding lymph nodes, which are very important. And we follow this on with chemotherapy for systemic control to treat the unseen spread. Sometimes we also use chemotherapy before the surgery, what we call neoadjuvant chemotherapy. And the reason we give chemotherapy before the surgery is to reduce the size of the tumor so that we can improve the quality of the surgical resection, improve the resectability of the lesion, improve the completeness of clearance of the cancer, and allow us to preserve more of the organ, right? Instead of removing too much of the organ that is affected, we're able to preserve more and more function for you. In certain cases, some cancers are also hormonally dependent, and we can also use hormonal therapy as a sort of a systemic therapy. So we can see breast cancer surgery, for example, has moved from this radical mastectomy towards smaller resections, right resections, and even now we just do a local lumpectomy resection followed by sampling of the lymph nodes. If the lymph nodes are positive, we clear the area of the armpit where the lymph nodes are. If the lymph nodes are negative, we may not need to even clear that. Sometimes we give a little bit of radiation to sterilize the place that we did the surgery, and we follow on with chemotherapy. So this is the concept of breast conserving surgery. From the turn of the millennium until now, I think we have recognized this is the era of technological surgery. Many advances have come about. Many tools we have to help us in our cancer surgery. And one of the major advances, like Dr. Ang has mentioned, is the improvement in energy sources. Okay, in the old days, we can only think of removing the tumor. Now we can use various sorts of energy sources to help us to burn the tumors. Sometimes we do not even need to remove it. For example, in certain liver tumors, we may use high-intensity ultrasound, microwaves, radio frequency to help to ablate, to kill the lesion. Okay? Even cryotherapy, so we burn, we freeze, just to destroy the area of the cancer. Not only that, we have the use of minimally invasive surgery, endoscopic surgery, laparoscopic surgery, even robotic surgery. And these have all helped us to achieve the similar rates of success using smaller incisions so the recovery is faster and better preservation of function. We have also had very important advancements in radiation. So not only surgery and chemotherapy, now we have another third arm that has come about in our multi-prong treatment. Radiation therapy helps us to give local control to the area where the tumor is by delivering high dose of radiation to that area while minimizing the dose delivered to nearby healthy tissue. Okay, we have various advances in radiotherapy such as three-dimensional conformal radiation, stereotactic radiosurgery, brachytherapy where they insert radioactive seeds in the area that require it. So all these things have helped us to personalize your cancer treatment. Okay, and no person with cancer is the same as the next person with the same cancer. Because of the complex host-tumor relationship, we have to understand what is required for you and then deliver what is required. So if you look at the cancer surgery timeline from the 100 years ago, we started doing prostate resections, tumor resections in the lung, in the colon, in the prostate, sphincter saving surgery. And now we have moved on to the era of very personalized cancer surgery. So where are we now? The aims of our cancer control program, first of all, we must look at the big picture, not just talking about treatment alone. In the aims of our cancer control program, we want to lower your risk of developing cancer. So we are forever trying to find ways and means to help you prevent cancer, screen for cancer, even cancer vaccines to prevent the onset of cancer altogether. Okay? We want to increase the cure rate of cancer by trying to diagnose your cancer early and by using various imaging modalities to stage your cancer as accurately as possible. Only by having good staging, then can we suggest what and personalize the kind of treatment for you. Okay? In cases that we cannot cure you, we want to convert you to a status of a chronic disease. Okay, so instead of having, although we know that we're not able to eliminate the cancer completely, we want to convert you to a chronic stage whereby you live with cancer but under control. Okay? And the final prong is that we want you to understand the genetic basis of cancers and identify specific molecular changes for targeted therapy. And I think Dr. Ang has mentioned some of these new things. They are very, very effective, very, very exciting, and there are lots of new drugs and targeted therapies, molecular therapies that are being brought onto the market in time to come. Therefore, the surgeon is not working alone now. We can see we are working as a team. Okay, so not just one superhero you have multiple areas of targeting treatment, and we want to personalize the treatment for you. Like Dr. Ang has mentioned, we meet very regularly in a multidisciplinary tumor boards, not just the surgeon, the oncologist, the radiation therapist, but even the X-ray specialist, the nuclear medicine specialist, the pathologist. We discuss your cases so that we can personalize the approach to each patient. So what is the surgeon's role in multi-pronged treatment? I think we are still very important, although we take the stage for only a short period during the surgery. The surgery may last 2-3 hours, but I think choosing the right operation for you, doing the right thing, makes a whole lot of difference to the ultimate outcome of your cancer treatment. Okay, so the surgeon is very important for helping with diagnosis and staging. We remove the primary cancer. Sometimes, even when the cancer has spread, we are able to do surgery to remove the secondary spread. In certain cases where we can no longer cure you, we can also do surgery to help palliate your symptoms. Palliate means to relieve the symptoms that you have. This is an example of a patient with a stomach cancer that has blocked the outlet of the stomach. He presented with vomiting, unable to eat. The scans that were done were unable to show any spread of the cancer. So in the old days, we would have made a big cut to try to remove the tumor. But instead, we did a small keyhole, put in a camera, because we suspected that this patient may have spread of the cancer beyond the stomach. And indeed, when we put the camera in, we found that he had small little spread in the abdominal cavity called peritoneal metastasis. Okay? So instead of having a big open and close operation that some surgeons used to do in the past, where we subject you to a big cut, we open up and found that you have spread, we close up and say, sorry, the cancer has spread, we can't do anything. And then you take another 1 or 2 weeks to recover from the big incision. So now we are able to make accurate diagnosis staging, put in a camera, laparoscope, to diagnose these things. And at the same time, because he was blocked, we were able to do a small keyhole procedure to do a bypass so he can eat again. All right? So the patient recovers from this within 3 to 5 days and moves on quickly to his next phase of treatment, which is palliative chemotherapy. So what is personalized surgery? We're not trying to fit everyone into a box. In the old days, we say you have stomach cancer, we remove the stomach. Okay, now we actually study what kind of stomach cancer you have, what is the location, the exact staging, the behavior, the aggressiveness, and we design the type of surgery to fit your requirement. So in cases where we feel we need to do more radical surgery, we are able to do more aggressive removal of the affected areas. In cases where we feel that you are actually earlier and good prognosis, we actually do less so that you preserve function for you so that you recover faster. So this is personalized surgery. So the extent of surgical resection is based on tumor biology, staging, patient factors. We try to use minimally invasive approach if we can, and when we feel that the cure of the cancer is not compromised. In early cancers, we also try to preserve the function. Instead of removing the whole organ, we do a partial removal. Okay? And in advanced cancers, we are able to increase the radicality of resection if we feel that you still have a cure. Okay? And the wonderful thing about having all these advances in chemotherapy and in tumor grafting is that cancer surgeons now feel that we're able to do more and more, because even if we leave a little bit of residual cancer behind, if we know that you have a minimal spread somewhere else, you will still have a significant durable control because we have all these wonderful chemotherapy drugs. So because of that, we are actually able to do more and more advanced surgeries. And I want to show you some of the more advanced things that we've done. I like to use the example of gastric cancer because that is my area of specialty and my interest. This is the stomach, the liver, the spleen that is around the stomach, the pancreas is behind the stomach. If you look at the kind of surgery people do for stomach cancer, there are two schools of thought. In the Western European areas, in Caucasian countries, they do what is called Western type surgery, where they remove the stomach and some of the lymph nodes around the stomach. Okay? But in Japan and in a lot of places in Asia, including Singapore, we believe in what we call radical gastrectomy. In other words, we not only remove the stomach, we also go on to dig and remove all the lymph nodes that are surrounding the pancreas, surrounding the spleen, surrounding the major blood vessel of the aorta, where the big blood vessel comes off, where we call the celiac axis. So we actually dissect and remove all these lymph nodes. So between Western type surgery and radical gastrectomy, I think the results are quite clear that doing this sort of radical gastrectomy improves the outcome significantly for you. But we do not do radical removal of the lymph nodes blindly. We do it according to a very detailed study of where we find the affected areas are. So we divide the lymph node stations into many, many areas that we dissect only if we feel that you require that area to be removed. A little bit elaborate. I hope you understand. Okay? So this is what we do. So for example, in the cancer here, we remove all the cancers, all the lymph nodes around the tumor here. Okay? And if you look at the cumulative incidence of death due to gastric cancer, if you do a simple D1 sort of surgery, which the Western surgeons do, the survival is not as great as if you do a Japanese type of D2 type of surgery. If the cancer is not so advanced, if the cancer in the stomach is very early, what we call early gastric cancer, where you can hardly see the tumor, then we do not need to even do such radical surgery at all. Therefore, we personalize the treatment. We do not give one operation for everything. Okay, so in these early cancers, you do not even require an operation. All you need is to remove the tumor, the spot of cancer, with endoscopic resection. We put a scope down the mouth into the stomach, and we remove a partial thickness layer of the stomach. Okay, endoscopic resection. Or if the tumor is slightly deeper, we may take a big wedge of the stomach using keyhole surgery. We can put a few keyhole instruments into the abdominal cavity, or sometimes directly into the stomach to remove the affected lesion. If we want to, and if the patient is suitable, we can sometimes also offer laparoscopic gastrectomy. Instead of doing the radical surgery to remove the stomach and the lymph nodes using conventional surgery, we can do the similar operation using keyhole. Okay, so this patient had a tumor in the middle of the stomach, and we did, the proposed operation was actually a pylorus preserving operation. In other words, we try to preserve function by preserving the pylorus part of the stomach that controls the outlet of the stomach. Okay. So, have we reached the limits of radicality in cancer surgery? I think it's instructive to look at the way we fail in terms of our cancer surgery. For abdominal cancers, stomach cancers, colon cancers, pancreatic cancers, there are three main ways where the cancer comes back. First of all, in the local regional area, in the tumor bed. For example, in stomach, it recurs in the stomach bed or the regional lymph nodes. What I've described to you just now, removing the stomach and the surrounding lymph nodes, tackle this area of local regional failure. Sometimes the cancer goes to the bloodstream and the patient fails in distant areas, in the liver, lungs, bones, the brains. These areas are now adequately treated by systemic chemotherapy. Okay? The last way which the cancer can recur is in the peritoneal cavity. Peritoneal cavity means the abdominal cavity where all the internal organs sit. Okay? If the tumor is in the stomach and the tumor has penetrated into the outer layer of the stomach, then there is very, very high likelihood that the cancer can drop out of the main primary and into various spots in the abdominal cavity. Okay, for example, they cause nodules there in the top of the liver, in the omentum, the small bowel, and even in the ovaries and the pelvis. Okay, this is what we call peritoneal spread. Peritoneal spread is one of the hardest cancer spreads to control because the peritoneal cavity is rather protected by giving systemic chemotherapy. So if you have a tumor in the liver and you give chemotherapy into the bloodstream, it often responds very well. But if you have peritoneal spread in the peritoneal cavity, often these spots of cancer do not respond to chemotherapy given that way. So what do we have in terms of treating this area? Now we are entering into the area of peritonectomy procedures. These are very extensive operations selected for certain people where we combine three things. We combine extensive removal of these little spots of peritoneal cancers, doing what we call cytoreductive surgery. We can even give chemotherapy directly into the abdominal cavity, what we call intraperitoneal chemotherapy. So instead of putting the chemotherapy into the bloodstream, we instill it into the peritoneal cavity and we use it to wash the abdominal cavity. We can either give it after the operation or best if we give it intraoperatively during the surgery itself. Okay? And if we do it intraoperatively while the patient is still under general anesthesia, we often use a third modality, which is heat. We heat up the chemotherapy, and we know that when we heat up the chemotherapy, the tumor responds to this far better than at normal temperatures. So another new superhero, okay? Heat that we use to tackle peritoneal cancer. So this is what we do. For patients with extensive nodules in the peritoneal cavity, after removal of the primary, we actually strip out all these areas of peritoneal spread into the pelvis, and when we're done, we instill chemotherapy into the abdominal cavity to wash this area. This is Dr. Paul Sugarbaker, who's the pioneer in this peritonectomy procedures, and I went to learn this technique from him some years ago. So this technique of peritoneal treatment is suitable for certain cancers which have spread to the peritoneal cavity, not for all cancers, because the procedures itself are very have high rates of side effects. Okay, so only when we feel that we can still cure you, then we do these therapies. Okay, and the good cancers that are treat in this way are appendiceal cancers that have spread into the peritoneal cavity. Cancers starting from the appendix have spread. Cancers from the colon, from the stomach sometimes, from the ovaries, some sarcomas, and they have arisen from the primary organ. They have spread into the peritoneal cavity. They do respond quite well to this. Now, there's one specific entity that's quite interesting that I want to discuss with you, which is this funny cancer called Myxoma peritonei. This is an unusual cancer which secretes mucus into the belly. So we derive this term called jelly belly. Okay, the patient presents with extensive cancer in the tummy and extensive production of mucus. Okay, in this cancer, with traditional therapy, traditional chemotherapy, 5-year survival is only about 50%. But using cytoreductive surgery and intraoperative intraperitoneal chemotherapy, we can achieve 5-year survival of up to 70%. This is a patient that we did, I think last year, the year before maybe. It's an Indonesian gentleman with jelly belly, okay? And what we did was actually a very extensive operation. Took us about 8 to 10 hours, where we removed all the spread of cancer in the abdominal cavity, okay? And we followed up by washing the belly with chemotherapy. Okay, this was in the Mount Elizabeth Hospital. Patient is doing well until today. He underwent 2 treatments where we had to open up. We did it twice. We opened up, we removed all the jelly, we did the chemotherapy, and a few months later he came back for a second washing procedure, and lo and behold, there was very little recurrence of the tumor left behind. Okay. So this technique is also now useful for colorectal cancers. In the old days, when you have colorectal cancer that has spread to the peritoneal cavity, the median survival is very low. So 6 to 8 months. Even with systemic chemotherapy, you have a chance of survival of up to 6 to 8 months. Okay? If you use additional therapies like biological agents, whenever they are suitable, maybe you get a better survival, 18 to 20 months. Okay? But after peritonectomy procedures, in selected patients with minimal peritoneal spread, we can even achieve up to 20 to 40% 5-year survival. Okay, so even you have colon cancer that has spread to the peritoneal cavity, there is still hope. And these results are very good, even comparable to resection of liver secondaries from colorectal cancer. So like Dr. Ang has mentioned, colorectal cancer that has spread to the liver, we can remove the spread in the liver, and you still have a 50% chance of surviving 5 years. So that first patient that Dr. Ang mentioned, the 40-year-old man with colorectal cancer with a few areas of liver spread, in the current situation, we can do surgery to remove these liver spread, and he can still have a 50% chance of surviving 5 years from the cancer. So this is what I talked about. Liver resection for cancer secondaries, and we do it not just for colorectal cancers. In certain other cancers, unusual cancers like neuroendocrine cancers and sarcomas, we also do it, and the results are similarly quite impressive. So we can do it either as a staged procedure. We remove the tumor in the colon first, and then we give chemotherapy, and after a number of months, we go back in to remove the liver cancer. Or some surgeons actually believe that we can do them both at the same time. So we do a combined resection. So even if your colon cancer has spread to the liver, we remove the tumor in the colon, we remove the tumor in the liver at the same setting. There are many techniques now we have to improve our chances of doing this sort of surgery. Instead of doing a big, if you have 2 little liver nodules here, instead of removing half the liver, we have surgical techniques now to enable us to remove just the tumor itself. If the remaining liver is not big enough, not strong enough, we can even use techniques such as portal vein embolization, which is a technique for us to block off part of the blood supply to enable the rest of the liver to grow. So when the rest of the liver grows big enough, we're able to remove the part of the liver that contains the cancer. There are other guided therapies we have for liver secondaries, like what Dr. Ang has mentioned. We have radiofrequency, microwave, cryotherapy, which is basically using a technique to freeze the cancer. Okay, so sometimes we do not even need to remove the tumor. We use therapies to ablate the tumor. Finally, for some cancers in the liver, where the liver is not healthy enough. For example, in certain hepatomas, even though the cancer is very small, if we remove the tumor, the remaining liver is not adequate enough to support the patient. In these cases, we may consider even liver transplantation. Okay, that means remove the whole liver together with the tumor and to transplant it with a new liver, either from a cadaveric or liver donor. But these are very specialized procedures which we apply to selected people. So the future of cancer surgery, we expect more and more effective chemotherapy and more targeted therapy, and to allow more and more aggressive and more radical surgery, which brings us the stage to the next step of our program, which Dr. David Sidransky will discuss with you after the break, which is a new approach to personalized chemotherapy. I think this is a wonderful, wonderful advancement because it allows us as surgeons to actually give you some a better personalized treatment for chemotherapy. And the role of the surgeon in our case is to actually think about using this technique during the time when you do the surgery, because it's very important for us to bank, like this patient that we did last year with a recurrent stomach cancer. We removed the tumor, and it was important for us to think about this technique during the time of the surgery so that straight away we can harvest the cancer and bank it and put it in mice, grow it, so that you have tumor avatars for us to decide what is the next best stage when you require this information. And I think Dr. David is going to talk to us all. We're all very excited to listen to his talk. Thank you for your kind attention.